Right, good afternoon and welcome to everybody who has joined this nice webinar on changes to the cost effectiveness threshold and the value set. My name is Sam Roberts. I'm the Chief Exec of NICE and I'm going to be joined by two people today. So we can go on to the next slide, which has got their names, and I'm just going to hand over to them to introduce themselves. Helen.
Hi everyone, I'm Helen Knight. I'm the Director of Medicines Evaluation here at NICE.
And Jack.
Hi, Jack Boothie. I'm the Deputy Director of Medicines Evaluation at NICE.
Great. So a little bit of context about what we're going to cover today before we get into it. So it's going to be split into two parts, this webinar. One part is we're going to speak for about 15 to 20 minutes, and then the remainder of the time will be questions and answers. So the questions and answers you should be able to put in your Q&A box, which you'll see at the bottom of your screen. In terms of what we're going to talk about, we're going to briefly explain why or the rationale for the changes to NICE's cost effectiveness threshold and EQ5D. We're going to explain a little bit about what they are and then how to implement them and next steps. So what we are not going to cover is any debate around the overall policy, the medicines access environments, UK competitiveness, etc. This is not a policy webinar. This is the government has made a policy decision. How is NICE going to implement it? This is an implementation webinar. If you have a company or that has got an appraisal that is currently underway with NICE, Jack and Helen will talk a little bit about how that is going to be managed, and the teams will be in touch with you individually. So this again is not a place for us to get into individual technology appraisals. That will be done confidentially with each of you in the days that come. Right, so that's enough about who we are, what we're going to cover. We're just going to get into, I'm going to cover now the why things are changing at NICE and what is changing. So on to the next slide, please. Next slide, please. Right. So you will have seen from the press releases by government and on the two things are proposed to change at NICE. One is the cost effectiveness threshold, and that is going to increase to £25,000 to £35,000 per quality adjusted life year. Just to remind you, the current threshold is £20,000 to £30,000. That's the first thing we're going to talk about, changing the threshold. The second thing is the government is supporting NICE to implement a new value set used to value health-related quality of life in health technology comparisons. So we're going to talk a little bit about that as well. In terms of the why, as I said, this is not a policy webinar, so we're not going to get into that in lots of detail. But the aim of these changes are to improve the pharmaceutical operating environment, and they were announced in terms of in the broader context as part of the US-UK economic prosperity deal. In terms of the impact that we at NICE have modelled it is likely to have, is that we estimate that we will approve 3 to 5 additional medicines a year due to the changes that you see on the right-hand side. And that is because, and 3 to 5 is kind of calculated from the fact that at the moment, we approve 91% of the medicines we see. That's about 70 a year. So this kind of is going to bump that, should bump that 90%, 91% up a bit. But as we say, kind of 91% is a relatively high approval rate as things currently stand. So that's the why, is improve operating environment for pharmaceuticals. And this is, if you think about NICE as balancing lots of different perspectives or objectives. On the one hand, we're thinking about what is the opportunity cost to the health and social care system. On the other hand, we're thinking about access to innovation. This is one of those government policies where the weighting is added towards kind of access to innovation. Right. So now what's going to change? On to the next slide, please. Okay, first of all, the threshold. We've talked about it already. It's going to change to £25,000 to £35, but £35,000 per quality adjusted life year. There are a couple of points on the bottom of this slide that may be just questions that have popped into your mind immediately when you saw this announcement. So first of all, it applies to all NICE technology appraisal guidance. That means it applies to all medicines and future health tech that goes through the technology appraisal route. So all technology appraisals, that's covered by our manual PMG 36. In terms of, does it apply to the rest of NICE health tech recommendations? Does it apply to guidelines? Our view at NICE is that it should to maintain parity across pathways, but it's not for us to decide. This is a government decision to change thresholds. So we are seeking kind of government and ministerial views on that. So we can't really confirm at the moment whether it's going to impact the rest of health tech or guidelines, but we will absolutely update our question and answer on our website as soon as we get direction on that. The second question that may be top of your mind is, does this apply to the highly specialized technology program? So this is where for ultra rare medicines, we've got a much higher threshold, in excess of £100,000 per quality adjusted life year. Our current understanding is that this increase in threshold will not apply to highly specialized technologies, that threshold will remain at 100 to 300K. But again, we are awaiting formal kind of confirmation of this position from government. And again, we will update our question and answer on this. And Helen is going to talk a little bit more later through this point, is that this change is not a change in NICE methods. This is a government policy decision. So you're not going to see it change through a normal NICE methods manual update. It's going to change through the Department of Health and Social Care will consult on powers to direct NICE. And Helen's going to talk a little bit more about how that will work in practice in a sec. Okay, so that's the first thing that's changing, increasing the NICE threshold for technology appraisals. On to the next slide, please. The second thing that's changing is that we will implement a new value set to quantify health states. So what does this mean? If you think about how NICE looks at things, we look at cost effectiveness, which is what is the cost relative to the benefit? And the benefit we think about in terms of length and quality of life. And so in order to understand quality of life, we need value sets that translate what members of the public think are valuable elements in life into numbers that we use in our appraisal. And so you'll see here that a study is now concluding that has been asking over 1,000 members of the public to judge these different health states and to translate these into what we call utility values. This is something that we've known needs to happen for a long period of time. We really welcome the research. We've been closely involved in it. And once that is peer-reviewed and published, we will go about implementing it following a consultation. So in distinction to the methods, which is really, in distinction to the threshold, which we talked about before, this will be implemented like a regular NICE methods update where there will be consultation, etc. Okay, so those are the two things that are changing, threshold and the value set for how we quantify health states, called the EQ5D5L. I'm now going to hand over to Helen, who's going to give us a little more detail.
Thanks, Sam. So I'm going to pick up a bit more about the implementation of the change to the threshold. So if we can go to the next slide, please. Yeah, so as Sam's talked about already, this change to the threshold is something that's quite different from a change to our normal methods that NICE uses when producing guidance. And we're going to be looking to introduce the new threshold from April 2026. And the reason that we've got that time delay is that there needs to be some work undertaken through the Department of Health to actually allow NICE or instruct NICE to be able to use that new cost effectiveness threshold. So there's going to be a targeted change to the regulations that underpin the work that NICE does. And really that is kind of clarifying in a way how we've already been operated, in that ministers in government are responsible for the medicines budget. So they decide how much of the budget should be spent on health, how much of the health budget should be spent on medicines, etc. And really that is in effect what the threshold is there to do. whereas NICE, through its methods, helps the NHS to be able to deliver that money as best as it can for the taxpayer in England. So this change is quite different to the usual methods change. So it will require a targeted change to the regulations, as I've said. That will take a little bit of time for that to go through. So you'll see on the right-hand side of the slide the anticipated timeline, which shows that we are looking to, getting ready to introduce this as quickly as we can from April next year. What NICE will need to do, although we won't be consulting on the value of the threshold or the fact that the threshold is changing, what we will do is a very kind of short consultation on how we're going to be implementing that. So we will need to update our manuals to reflect the new thresholds, and we'll be doing a short consultation on what that will look like and how we're going to implement it. Obviously, I'm going to talk you through how we're going to implement it in the meantime, because April is a few months off. So I think really what the take home message is from this slide is the threshold change is very different in terms of how we're transacting and bringing it into use within NICE than it is for a normal methods update that NICE undertakes. So next slide. So this slide will be of interest to many of our companies and patient organisations. Other stakeholders are involved and watching the medicines that come through our work programme. So what does this mean? For all new and ongoing appraisals, they will continue as planned. And what we are going to do is apply the current threshold until we get a direction from the Department of Health that we can actually apply the new threshold. What we are trying to do is make sure that we can maintain a work programme, maintain access as quickly as possible for patients. Once we get a direction from the Department of Health, we will then start to apply the new threshold, regardless of whether or not a technology appraisal is in flight, is ongoing, or whether it's starting next year. So that's really important, that the way that we're approaching implementation is trying to keep the operational aspects on track as much as we can to help support fast access for patients where we're able to make recommendations. Important to note as well, and no doubt we'll have some questions on this, we won't be routinely revisiting previous NICE technology appraisal guidance. We will use our standard approach to making any updates to published guidance. So if we've not recommended a medicine in the past, we will review it or consider it for review if there's significant new evidence that would make a material difference to that recommendation. So that will still apply. The fact that we have a new threshold does not automatically mean that we will relook at old guidance. On our usual approach will apply. So for those topics that are currently ongoing and have committee meetings coming before April 26, we are kind of using like a categorization, 3 different categories of topics. If a topic is found cost effective under the current threshold, then we'll be looking to recommend it as usual. As I said, that's important for us to maintain fast access for patients who need these medicines. The second bucket is if a topic is not cost effective under the current threshold, but applying the new threshold could change that decision and lead to a positive recommendation. We will pause that topic and not publish final draft guidance at that stage until we can apply the new threshold and we've had that direction from Department of Health. Once that threshold comes into force, we will then automatically apply an increase to the threshold that the committee had previously considered was appropriate for decision making. And that will be what leads to the guidance that gets published. So for an example there would be, topic has gone to committee, their preferred threshold for a product is £25,000 per QALY gained. If that's currently not recommended at that threshold, but it could be recommended so that the cost effectiveness actually is £28,000 per QALY gained. We will pause that because we think that implementing the new threshold would actually lead to a different outcome, because under the new threshold, the committee would be using a £30,000 per QALY threshold. So obviously we're going to aim to continue our publication processes after that and the commercial discussions that are required after that. That will kind of try and mitigate any delays to patient access as much as possible. The third bucket is if a topic is found not cost effective and wouldn't be recommended even under the new threshold, then we will still continue our normal timelines to publish negative guidance. That's because implementing the new threshold is not going to lead to a change in decision from the committees. So important to think about those three different buckets. As Sam said at the beginning, and Jack will reiterate, we are going to be contacting each company individually on the back of this decision to make sure that they are super clear on exactly what will happen for their topic moving forward. So Jack, I think I'm going to hand over to you to talk through implementing the value set.
Yes, thanks very much. Next slide, please. So as Sam has explained, we are anticipating a new value set to become available in early 2026. And just to explain a little bit further what that means. So the EQ5D instrument is NICE's preferred measure for measuring health-related quality of life. And a value set is ultimately how we translate those measures into health utilities, and that is what we use to calculate quality adjusted life years. So the reason that the potential implementation of a new value set is part of these value set of measures is because ultimately based on what we currently understand about the new value set that isn't yet published, is that it can alter how much value we put on different health states. And that ultimately influences quality adjusted life years and therefore also kind of the cost effectiveness of medicines that we evaluate. And that is why it is important that we consider both the implications of that, but it does for some technologies have an impact on ultimately the cost effectiveness estimates, and therefore ultimately it can have an impact on prices as well. So that's why it's kind of part of these sets of measures. So in terms of the delivery, though, as Helen and Sam have said, so this is very much going to follow our standard modular updates process for making methods changes to the manuals, which means that as soon as the value set is publicly available, we will start that process. And that does also involve a consultation with the public that will both explore how the new value set will impact our evaluation of technologies and how we're proposing to implement it, and the question whether we should implement it. So that will all happen in over the course of the first 6 months of 2026. The exact timings are unknown because it will depend on the peer review and publication process. So next slide, please. So just before we go to the Q&A, a couple of things about next steps. So we will cover, I'm seeing many questions come in, so we probably won't be able to answer all of them here. But if we haven't addressed your question in the Q&A, there is more information that you can find on our website. And you can also contact us directly via the email address that you can see on the screen here. And as previously indicated, especially for companies who have a topic that currently is in our work program, the associate director or principal advisor leading your topic will get in touch with you over the next few days to provide all the information that you need, and also specifically what we think the potential implications are for your particular topic. I know some of you have already been in touch with us, But if you haven't yet received an answer, please bear with us, as we do intend to write to all of you over the next few days to answer the questions that undoubtedly you will have. And finally, we will continue to engage everyone throughout the implementation process. So it does require a short consultation on the provisions that we need to make in our manual, as we've just explained them here. And there is a nice public board meeting next Wednesday afternoon where this is also an item on the agenda. So Sam, it is over to you for the Q&A.
Great, thank you so much. So for folks who we're now into the Q&A, thank you for those who have already put lots of questions in. If you click on the Q&A tab at the bottom, you should see what the questions are coming up. We're going to deal with the first one is on severity, or there are a couple. So Helen and Jack, you can decide who wants to take that. People have asked two groups of questions that we are not going to address today. So just to kind of remind you, one is on the rationale for the government's decision. So NICE's view is that it is, in a tax-funded health system, it is the preserve of the elected government to decide the proportion of spend on healthcare and on medicines. That is what the government has done. We're not going to kind of second guess or editorialize on that government decision. We're mainly talking today. We are only talking today about how we now implement that decision. There's a second group of questions which are around, well, how can the NHS afford this? And again, we cannot cover that today because we're not privy to, we are not responsible for or privy to the decisions around funding flows, etc. That is the preserve of the Department of Health and Social Care and NHS England. So please forgive us on those 2 points, the two groups of points, rationale for the policy and how it's going to be funded. There's some very important questions coming in that NICE, as you can understand, is not the right person, is not the right organisation to be answering then. What we are the right organisation to be answering is how is this going to work in practice? So that's what we're going to focus on. Right. First group of flurry of questions are around severity. So Jack or Helen, do you want to start with, there are a couple, so I'm going to give them to you one by one. What are the implications of this change for the severity modifier? Let's start with that one.
Yeah, so the simple answer is we will transact the severity modifier as we currently do. So just to remind everybody how we do that, we apply a weighting to the quality adjusted life years, the incremental QALYs, in an analysis before the committee then make a decision about whether or not the medicine is value for money for the NHS. So previously, the weighting is applied to the QALYs, and then committees have then said, is the incremental cost effectiveness ratio between £20,000 and £30,000 per QALY, and is it considered that it can be recommended for the NHS? The same will happen at the beginning. The QALY weighting for severity will apply and be transacted onto the QALYs, and then the committee will then in future use the new threshold of £25,000 to £35,000 per QALY gained. So the way that the severity is used will not change, and nor will the cut-offs for the modifiers change either.
Great, thank you. So I'm going to ask two questions now that combine severity, and then they go on to the value set work. And so I don't know whether they go to Helen or Jack, but you can decide which picks it up. So the first question is, where did the new value set emerge from? Was it an existing NICE initiative or something that came through in the trade deal? And then the second is the value set work different to the ongoing work about societal preferences for the severity modifier?
Shall I answer those? So the answer to the second question is yes, it is different. So they are two completely separate pieces of work. So there is ongoing work in looking at societal preferences, specifically around how the severity modifier works and the societal preferences for valuing treatments that treat severe conditions differently. The value set itself is a piece of work that hasn't been instigated as a result of kind of the trade negotiations. It is a piece of work that was initiated several years ago because setting up kind of the data collection and then the data analysis takes a while. It is academically led, independent from NICE. But because it does have important implications for our work, we have been kind of closely involved and keeping an eye on how the work has progressed, which is why we are aware of it coming, and have been working through understanding what it might mean for our evaluation, such that once it becomes available, we can start that process for considering implementing the new value set. But it is independent, academically led, and has already started several years ago before the trade negotiations.
Yeah. Great, thank you, Jack. And while we're talking about the 5L and 3L, there is a question from a very valued former colleague. Hello, Jazz. And he asks, is the new value set for the 5L instrument only? If so, are any changes expected for the 3L instrument currently used?
Yeah, good question. What we are anticipating is that once there is a 5L value set, that if the 3L instrument has been used, that values will need to be mapped in the same way that currently happens, kind of in the other way around, because we already have provisions for mapping to 3L when the 5L instrument has been used. And apologies for those who are not in the detail on health economics, but it was an important point to clarify.
Right. And then there's two other questions on the value set, and then we'll go into some of the other ones. So one is, how will the transition period for the new EQ5D value set implementation work? Will it only be considered after the methods guidance update? And the second is, will the EQ5D 5L value set be expected to be used in submissions that get appraised in 2026? So kind of two similar questions.
Yeah, again, great question. So what we will do is that as soon as the modular update process initiates, which will hopefully be early next year, we will provide more detail on what we are proposing, on how it will be implemented. Usually what happens is that there will be a certain kind of cutoff date from which point forward for topics the new value set will apply, because the use of the value set does require and changing from 3L to 5L does require additional kind of analysis and adaptation of economic models. We will have to consider as part of the modular update exactly how it will be applied and whether it will be applied to both ongoing as well as new topics. We'll communicate on that as soon as we initiate the modular update process.
Great. So then there's another group of questions maybe for you, Helen, around submissions that were deemed to previously not be cost effective. So there's two here. Will this only be for new submissions? What about previous submissions deemed not cost effective with the old threshold? Can they be resubmitted or reconsidered? And does NICE have capacity to review multiple resubmissions of previously rejected treatments if companies feel they can now gain approval under the new threshold?
Yeah, so as I mentioned before, obviously in the past we've not recommended certain medicines, and it has always been NICE's policy to be able to review those recommendations if there's new evidence that suggests a different decision would be made. So we're very open to discuss with companies who have had a not recommended medicine and would like to come back through NICE for a reevaluation. And we will look at that evidence and establish if the new evidence from the company or any other stakeholder that thinks that they've got new evidence that could change the decision would change the decision. And that's when we will be looking to actually do a review of the guidance at that point.
Great, thanks so much, Helen. And there was also one about, Chris Sampson's asked, is NICE planning an internal assessment of impact? And if so, to what extent will these be made public, particularly referring to the threshold change?
Yeah, so I'll take that one. And also, Sam, I just remembered the capacity question. So again,
yes.
if we are reviewing guidance, then we would have to work that through. We do have capacity where it's needed, but it just needs careful understanding of when information will become available and when we're able to fit that in comparison with all the other topics that we have in the work programme. So in terms of tracking and monitoring We track and monitor a lot of our evaluations, and people who attend the board will see our performance report that talks about the proportion of topics that we say yes to, which recommendations are optimised, where we're seeing terminations. And so we will still continue to track that. In terms of specific change to the recommendation, we won't be doing anything we won't be doing anything new on the back of implementing the new thresholds. We have some internal data. Obviously, the thresholds through which we say yes are often confidential because of pricing arrangements. But obviously, we keep an internal log of that, but we're not going to be reporting anything significantly new because of the change to the threshold.
Great, thank you so much. And also, Chris, on your impact assessment, remember that this is a government policy decision. So our understanding is that the government is undertaking an impact assessment. And sorry, we can't talk. I don't know actually whether it is going to be published or not. I'm not kind of completely on top of how other government departments do it. The second thing is Chris Llewellyn. I wonder if it's the Chris Llewellyn I know. If it is, hi, has said, how is this going to be? How people are going to be able to access the recording. So the recording is going to be available of this on the NICE YouTube channel. Apologies, it takes a couple of days to get from here onto this because we need to add the kind of closed captions onto the recording. Right, let's go back to the Q&A and see if we've got any more coming through. There's a couple on whether this applies to devices, diagnostics and digital, which I think we answered beforehand. Yes, it will apply to those that are going through the technology appraisal routes, i.e. those that are going through the rules-based pathway, which is a minority of the topics, and we're seeking government clarity on whether it will apply to the rest of the health tech programme. Right, let's see if we've got any left.
Sam, I think there's a few just to pick up on the managed access, CDF, IMF, etc. So I'll maybe pick those ones up. Yes, if we're undertaking a review after a period of managed access in the CDF and IMF, yes, the new thresholds would apply in the same way that anything that's in flight and a new appraisal starting, we would apply. And there was also a question about what threshold would be used with regards to commercial negotiations or commercial flexibility through NHS England. So it's my understanding that, yes, the new thresholds will be applied to that. So where they currently say commercial flexibility, they expect value at or below the lower end of the threshold, that won't be £20,000 anymore. It will be £25,000.
Okay, great, thank you. And now there are a couple which are not in your, you can see the answered, which I think we've gone through everything in the answered pile. We've got a couple of questions that we can see privately that haven't been moved over to you. So I'm just going to go through some of them. So the first one is, your assumption of 3 to 5 more medicines is helpful. Have you done the analysis to see if of the 91 that got approved, how many would have included a wider population of patients or full indication approval with this increase in threshold? Great question. Jack, would you like to answer that?
Yeah, thanks very much. So we haven't specifically looked at that in a great amount of detail. What we are expecting is that it might make a bit of a difference for some topics, but we don't think that necessarily, based on how we understand decisions about kind of optimizing populations currently works, that we're expecting a very significant impact there. But we've not explicitly explored it as part of the impact assessment.
Great. And Jack, while you're on the roll, there's one about how will NICE implement the changes with respect to the cost comparison route, as comparators will have been through the previous approach with a lower cost effectiveness threshold?
Yeah, good question. So we're not anticipating making changes to the cost comparison processes and methods used there. Those will remain the same. And I think it will be up to companies to consider whether they think that is an appropriate route for the evaluation for their technology.
Great. And then there's another one. How much consideration has been given to what will be happening to interventions falling into the southwest quadrant i.e. those that are less costly and less effective. There, new interventions will need to demonstrate slightly greater savings per quality foregone. Any thought on farmers' reaction to this? What will this do to the number of interventions approved?
Yeah, good question again. So the manual is very clear on how we transact kind of ISOs that fall in the southwest quadrant. So for those with less expertise understanding, that means that some interventions that NICE looks at are slightly less effective than what the standard of care is, but also can be significantly cheaper. So our committee and our manuals have specific instructions for our committees on how to make decisions in those situations. That says that we apply the same thresholds in that quadrant, so those will also be adjusted.
Great. Then there are a couple of questions about how can we get more detail on the underlying research on the EQ5D, 5L? So this is academic work. It's been submitted to a journal. It's undergoing peer review now, as we understand it, and it will be published in the normal way. So we won't kind of cover lots of questions on that because you'll be able to see it in the published literature. Okay. Sorry, I'm trying to, it's quite hard, there's so many screens. I'm trying to think, what else do we need to cover, Helen, Jack, that we haven't?
So I have seen a couple of questions around how we are managing the potential impact, potential delays that we are seeing. So just to say that, we have spent considerable kind of time figuring out what the potential kind of how we could implement these changes in the least disruptive way possible. So we are planning, as Helen has set out, in how we are proposing to implement this. We are confident that will kind of minimize capacity issues on the NICE end of things to keep topics running to time as much as we are able to, as well as not creating a very large backlog from April 2026 onwards. I think over the next couple of weeks, we will have to assess after we've spoken to companies and I've heard their views on this as well, on how that will pan out in practice. But we are confident that this is a pragmatic approach to how we can manage these things in a way that we hope will cause the least amount of disruption as a result of these changes coming into force.
Great. There's another question. So I think you've answered the questions around commercial framework, but there's one about the budget impact test, which will there be adjustments required for budget impact test, which has been increased to 40 million recently?
Well, yeah, good question. And I think obviously the budget impact test is something that is kind of more owned. We transact it for NHS England. But I think that's, I haven't got a signal that will change right now, but that is something that we need to have a conversation with NHS England about to understand whether or not that needs to change.
Great. There's a couple of it that are in the kind of how we manage pauses category. So Helen and Jack, I'm going to read them out and then you can say whether you feel we've adequately answered them. One is, do we know how many are expected in the paused bucket? If the threshold change means 3 to 5 additional recommendations a year, is that a reasonable estimate for the number of pauses? And the next one is, will treatments that have recently been assessed as not cost effective, but where final draft guidance is not yet published, be eligible to be paused, to be considered against new thresholds?
So we've looked at some numbers, haven't we, Jack? Because we know what's going through the committees at the moment. I mean, there are a significant number. So we've got about 40 topics with a second committee discussion before April. We've got about 20 that are kind of after committee, but we haven't released final draft guidance on. So obviously there's going to be a proportion of those that fall into those 3 different buckets that I talked about earlier. So there'll be some that we can recommend and we should crack on and do that. There'll be some where the new threshold will make a change to the decision, and they're the ones that will be paused. And there will be a proportion that will not be recommended or unlikely to be recommended even with a new threshold. So I think what we don't know yet is the proportion of those ongoing topics that fall within those different buckets. So it's quite difficult to say at the moment until we've kind of worked that through in more detail.
Great, thank you. And then there's a question here, which is, we're now going back to this idea of which previous negative recommendations can be revisited. So somebody's asked, is a change in the threshold considered new evidence for the purpose of revisiting a previous negative recommendation? And the answer to that is no. You can find more details in the our Q&A, but as always with revisiting recommendations, is there substantial new evidence around the intervention? Just the change in threshold is not enough to consider revisiting it.
Yeah.
Right. We're coming to the end of time. So could I ask Jack and Helen and Flo and Ed, is there anything in the many questions that we've received? Obviously, we couldn't cover every single one that you think we haven't covered before we move on to next steps.
Nothing stands out. And just to say as well that there is a Q&A on our website as well, where more information also can be found.
Great. So I think this brings us towards Helen. You any kind of big topics that you see in the Q&A that you think we haven't addressed yet?
I don't know. I did see one about, does this apply just in England and Wales, and what about
that's a great one. Yep.
Scotland, Northern Ireland, etc. I mean, we can only comment on what we're doing. So I think, you know, that question probably is more for the government to answer. I know that kind of devolved nations have been part of those discussions, but I don't have clarity on exactly what that means for areas outside of what we deal with.
Great. And sorry, there's one other question which we probably want to do before we go, and that's around who will be aware that there's a pause to a topic. So it says, for ongoing TAs, will other stakeholders be made aware if a topic's being paused to assess the impact of the upcoming threshold change?
Yes.
Yeah.
Great. That's very simple. So I think this just leads us to say, obviously, people will have lots of questions. So there are three kind of ways that we're going to keep you informed. First of all, there is a Q&A on our website, which has been linked to in a lot of the answers to these questions. So go there, have a read through things. As we're getting more and more questions, we'll add to that Q&A. The second thing is, if you've got a live topic, remember the teams will be in contact with you in the coming days to explain exactly what's going to happen and talk it through. And then lastly, if you've got other questions that aren't answered by either our Q&A or if you're a live topic, a reminder that we do have an inquiry handling team. It's nice at nice.org, and they will be able to answer further questions. And we'll monitor the kinds of questions that people are sending us through our inquiry handling and update our Q&A. So I think that leaves us to say thank you so much to everybody joining for your kind of thorough and thoughtful questions. And we look forward to working through this implementation with you. Thank you so much. Bye-bye.